السلام عليكم ورحمة الله وبركاته. Dear critical care doctors, this is going to be our first quick capsule video through which we will discuss subtopic related to our daily practice in ICU very quickly rather than discussing a large topic over 1 hour. So the first presentation of quick capsule videos through which we are going to discuss the role of body weights in intensive care practice. Firstly, we know what's called the total body weight, which consists of two main parts, lean body mass and the fat mass. So what we are really concerned about is the lean body mass, because most of the cardiac output is directed to that part, and the volume of distribution of most drugs given in critical care is directed also to that part. So if I have a patient, his body weight like 120, 130 kilograms, the would be very serious if we do the drug dosing for this patient based on his actual or total body weight. So the problems is going to be regarding drug dosing. If I used his total body weight to prescribe the drug doses, most probably he will receive toxic doses of medications. Second problem is the dose related to the tidal volume on mechanical ventilator, 6 ml per kg. Should I use his total body weight here? Most probably he will develop barotrauma and the ventilator-induced lung injury. Third question, the dialysis dose, CVVH dose, 30 ml per kg per hour. Should I use his total body weight here? Last question, the nutrition dose, which is 25 kilocalories per kg. Should I use here his actual or total body weight here? The problem is using the total body weight in morbidly obese patients is going to develop or cause serious complications like drug overdose, overfeeding syndrome, barotrauma. So that's why we need an estimate, or let's say rough estimation, for his lean body mass. So the first trial to do so was in 1974 when ideal body weight was presented for the first time. This is the equation of ideal body weight for both male and female, and as you see, it depends only on knowing the height of the patient. And after presentation of ideal body weight, it was used in drug dosing and in mechanical ventilator tidal volume dose and in nutrition dose. But with time, its drawbacks and the disadvantages start to be very clear for us. And the idea behind that, let's imagine if we have 3 patients with similar heights exactly. The first one is 90 kilograms, the second one is 110 kilograms, the third one is 130 kilograms. Despite having different body weights, different fat masses, different lean body masses, but when we estimate ideal body weight for all of them, it would be the same exactly. So I will prescribe drug dosing which is very similar for all of them, which might be fine for the 90 kilogram patient, but would be underdose for the 110 or 130 kilograms, which is not logic. So they started to think about some adjustment in the ideal body weight. So now we have the adjusted body weight, which is adjustment done in the regarding the ideal body weight and taking in consideration the actual body weight of the patients, which is logic now. So they used the factor 0.4 for this adjustment. Now I have adjusted body weight, which is used mainly for drug dosing in morbidly obese patients in ICU. And when it was used for nutritional support dose, 25 kilocal per kg, the problem that they found a lot of cases complicated with overfeeding syndrome. So they presented what's called the nutritional body weight. It is the same equation exactly of adjusted body weight, but with the only difference, this factor, 0.4 and here 0.25. So to make sure that the patient is receiving less dose of nutritional requirements and to avoid overfeeding syndrome. So now we have 4 types of body weight, and we use all of them in our practice. So we need to clarify all of them now. We have total body weight, ideal body weight, adjusted body weight, nutritional body weight. This is an example, a very nice website, clincalc.com. I advise that every critical care physician save this website on his mobile phone, because you are going to need it every day. And here you just put the patient's height, actual or total body weight, and his gender, and the program will tell you every parameter we told about. Ideal body weight is 70 kilograms for the patient who is 120 kilograms. Adjusted body weight is 90, nutritional body weight is 82. So the least one is ideal body weight. This is an example for the 4 weights of the patients. So let's go back to that slide. Which one should I use for the tidal volume on mechanical ventilator? 6 ml per kg. Which one? Ideal body weight. The least one, because this is the safest ever to guarantee that the patient would be away from barotrauma and possibility of ventilator-induced lung injury. For hemodialysis dose, it's still debatable part whether to use ideal or total body weight, but most of hospitals use total body weight for CVVH dose, actually, because we need to clear up all the body volume. So that's why they use total body weight in this case. For the nutrition, 25 kilocal per kg, nutritional body weight. The last one, the drug dosing, is quite complicated, because sometimes I might use ideal body weight, which is the least one, especially if we have more dangerous medications like sedatives, benzodiazepines, propofol, non-depolarizing neuromuscular blockers like ricuronium, like atracarium, cardiac medications like amiodarone, thiophelin, anticonvulsants like phenytoin. When we prescribe all these medications, I prescribe them based on ideal body weight. We might use adjusted body weight for vasoactive agents, for antibiotics, especially aminoglycosides, for anticoagulants. And finally, I can use total body weight for drug dosing with succinylcholine, soxamethonium, the depolarizing neuromuscular blocker. Do you know why? If you know the answer, write it in a comment. Why we use total body weight in succinylcholine prescription and not ideal body weight. Thank you.